Okay, so I'm Erin Sullivan, and I am going to take you through a story, and I'm going to talk to 16 slides, and I'm going to try and do it in 10 minutes. And as what I invite you to do is be in the story. And as you're in that story, and even for the men in the room, I ask you to think about a woman's journey as she becomes a mother, okay, a mother's story. And when you think about that, I'd like you to contextualize it as how does a public health nurse join her in the journey, positioning her as the expert of her life and the nurse as a guest. Okay? Before I start, and I'm going to start to laugh because my man friend told me a funny story last night, and I'm thinking about that right now, so I'm trying not to. I need to thank my family for supporting me, my allies, and all the brilliant women online, and the faculty, and my good friend Liz and Jan, who helped me in this workplace placement. Okay. Oh, she's back. And thank you to the New Channel Tribal Council for sharing their program with me. The clock isn't running here, so I want to just make sure someone's counting. Thank you, Victoria. Okay, so this is how we're going to do it. I'm going to talk to you about a bit of the context. I'm going to describe a bit of the literature. I'm going to say how that has implications for public health nursing, and then I'm going to give a couple reflections. So the context is, Island Health, public health nursing is in the business of being in service to women, and they want to do some quality improvement, and they want to focus on public health nursing, prenatal home visitation, and they especially want to improve their service engagement with Aboriginal women. And how do they want to do it? They want to look to adaptation of the mother's story program approach that has been in place with the New Channel people for many years. I'm going to say 5, and Liz, you can correct me. I know you're online if I'm wrong. So we needed to look at what. What is it? What is home visitation, okay, by public health nurses, and how do they perform the intervention? How do they join with women in the journey of becoming a mother? Okay, and how can we do that really, really well? So I endeavored to do the literature review, and this is supporting my workplace placement, so this is in the context of Island Health, right? So we did a review, we looked at some of the literature, and how it was included, and what we decided to include was based on these words. And words, as Cheryl alluded to, have all sorts of different connotations, strengths, challenges, and dependent on the article I read, how they describe the population. So I just wanted to highlight that. That's the purpose of this particular slide. Oh, and if I'm talking fast, just remind me. Okay, I mean, I've had the experience of elevator speeches. So what the results told us, that there were some slides that some studies that really looked at public health nurses' home visitation in the prenatal period. Okay, so those were included. And then what I wanted to look at was, what about Aboriginal women and their experience of maternity care, okay? And really a focus on Canadian women because of the interest of Island Health really wanting to improve that service engagement. So this is what was included. So then we talked about what I found with nurse home visitation is that were some result themes. 4 of them are listed here. When you talk about utility as an intervention strategy, what we're looking at here is, or what I found, was that home visitation is actually an umbrella term, and it can represent many different types of services and supports that are delivered to women considered priority populations. And these priority populations are experiencing vulnerabilities due to advantageous exposure to the social determinants of health. Okay? They're an opportunity for education and support, coordination of care for these specific women. Okay. There was a variety of models. Now remember, my research was interested in, or the lit review was interested in nurses, but there are a variety of models, and they can be who's delivering them, how often, how do they engage in the relationship with the client, okay, how do they invite themselves in, how are they implemented, and whether or not they are actually evaluated. Moving us nicely into evaluation. So what did the studies tell us that they evaluated? I would say there are 4 main themes when we think about this. First of all, studies would look at, when they're looking at home visitation, the study was looking to justify it as an intervention that would decrease social costs, specifically those costs associated with social welfare system and the justice. Okay? Then you would look at programs that their purpose was to improve a healthy childhood early development. Premise being, if you enhance maternal parenting capacity, then you will, through that, improve the child's ability to develop in a healthy manner. The third is improving health outcomes, and this was kind of a health and social was a very interesting piece to look at. Some of them are very specific medical health, okay? So they're looking at preterm birth, low-term birth weight, breastfeeding, access to maternity care. Some of them were social, and that's when you got into the prevention of child maltreatment. And this is why I've highlighted here the nurse-family partnership. And the nurse-family partnership, has anyone heard of this model? Okay. If you've been in BC, it's had a lot of press in this last little bit. It dominates as a model the literature. Okay, dominates it. And it has been set up as a 27-year longitudinal study. Okay, and fidelity requirements and all the pieces around it. So it was just interesting to see it come up. Okay, it measures 3 specific things: mom's pregnancy intervals, involvement in the workforce, and less reliance on social assistance. So very specific outcomes for that particular evaluation. What I noticed when I reviewed the literature, that there were gaps in the evidentiary base, and that's my rudimentary description of what I noticed. They would link, say, oh, this would be better to do next time, kind of discussion. What we would see is that people talked about the precision of evaluation in this field is essential, but we're not there yet. Okay? And the studies, because the studies don't often identify which intervention is specific to the outcome. So what is it that helped that breastfeeding rate? What is it that stopped the preterm birth? Okay. The second thing is, they talked a lot about it is the relationship between the nurse and the mother that is key to intervention success. But they didn't really describe how she did that, right? How did they do that? They talked about relational practice, and I'm going to talk about that a little bit, okay? And then home visitation in Aboriginal women is very, very minimal existence in the literature. So that's why I took a looking at, okay, when we look at maternity care broadly in Aboriginal women, what do we learn, especially in Canada? Well, what we learned that there is huge disparity, and we've learned a lot about this in our program, between if you're looking at Aboriginal women's outcomes during pregnancy, there are higher rates of preterm, low-term birth weight, macrosomia, so that means big babies, infant and perinatal mortality, higher rates, okay? And that they also experience access to healthcare issues that are related to, could be their geography, that they're living in a rural area and hence don't have the opportunities that someone living in a non-rural area has. And they also have experiences of racism, being labeled as non-compliant, being labeled as too complex to deal with, as some of the words used. And so they do not choose to access care because of feeling isolated and marginalized. The third thing that we talked about, or the literature talked about, was the importance of culturally safe maternity care, and that's being strength-based and inviting the woman and respecting and having her explain her life's context so you can join her in that journey. And that is how you achieve outcomes, through culturally safe maternity care. So when we're thinking about public health nursing, home visitation, and you're thinking about that mother's story and how we support her, and you think about Island Health saying, we want to look at, I've got more time here. What is it going to be like? What do we do? What are our adaptations to the Mother's Story program approach? What we know is there are subgroups of girls and women that do experience much higher risk. Okay? What else do we know? The practice framework matters. It matters a lot. It is relevant to quality, it's relevant to access, and it's relevant to the outcomes. Okay? It aligns, if you're looking at a relational model, so that piece about the practice model that's relational aligns very nicely with core public health values and competencies. By understanding those broad determinants, you can contextualize risk and form the relationship with the woman. The limitations, there are plenty. The ones I'm going to highlight on again is that nurse-family partnership dominance. Okay? The project strengths was that this was really a quality improvement focus of the health authority. The challenges, limited literature, as well as a really specific setting. And what did we conclude, or what did I conclude? Home visit has utility. No models have been evaluated for Aboriginal women. Am I there? Best practices do exist for engaging with Aboriginal women in maternity care. That this literature might inform this adaptation of the mother's story, that the practice platform is essential and relevant and must include the components listed up here. And the adaptation may address the service gap that Island Health has expressed they have, improve their service delivery to priority populations of women, and increase accessibility by Aboriginal women. And there's other things to look at, and these are what I think they are. We're moving to relational, away from medical model expert. Thank you.
Thank you so much, Erin.
You're welcome.
Are there questions?
Micah. Oh my
Actually,
gosh.
really just a comment, Erin. I so appreciated your presentation. I actually chair the Nurse Family Partnership Data Security Committee. So just for your information, that is to ensure that the protocol is being adhered to, that there are no adverse events happening, and that there are decision rules to stop what is a trial, essentially, a clinical trial, in this case, an intervention trial. And just around the issue of engaging with Aboriginal communities, it is forbidden in the context of the protocol of the study to actually provide any contact on reserve or really to First Nations populations, partly in appreciation of cultural sensitivity and wanting to avoid the expert thing, partly in recognition of the role of the Aboriginal Health Authority and sort of being clear about the role that they're going to play in this emerging new landscape. And so we have several discussions about this as kind of one of the weaknesses of the trial, but also understanding completely why it is that that Aboriginal populations will largely be excluded from the trial, in the hopes that some of the things that you're talking about might be brought to bear in future research about best practices that are culturally appropriate and sensitive.
If you need the mic.
So hi, I'm Pam Rye. I'm one of the MPH candidates, and I'm also a practicing public health nurse who's fully aware of the Nurse Family Partnership, and I see lots of potential and lots of value, but I agree with such a large focus on NFP, there has been a shift away from some other important priority populations. And I understand, Michael, you're expressing what the limitations are, but also, you know, requiring English as your primary language to participate. Really, it's filtering out a lot of valuable information. And I acknowledge that you recognize that that's a limitation. So thank you to both of you.